distinguished guest, Professor Alan Barkun, who is one of the pioneers in North America and worldwide regarding GI bleeds and the use of IV PPIs. And he's very well expert in PPIs, and he's going to tell us today about are they safe in the long-term therapy. Professor Alan.
Thank you very much, Mr. Chairman. Salam alaikum, everyone. It's a pleasure to be here again at the Society's annual meetings, and I'd like to thank the Scientific Committee, in particular Dr. Faisal Batwa, for allowing me to present to you today. I've been asked to speak to you about PPI side effects, and it's a very confusing area with a lot of recent publications in the literature. I'll try to do my best over the next 20 minutes or so to highlight the key factors that will help not only you make decisions, but also help counsel patients and make decisions in this area. Very briefly, with regards to disclosures, I do work as a consultant and have done research with two of the PPI makers on a global level. So the learning objectives are to assess the safety profiles of PPIs, placing current concerns in appropriate clinical context in order to minimize the risk of adverse events while maximizing the overall clinical benefits of the PPI therapy. And in addition, discuss the current thinking with regards to a possible PPI clopidogrel interaction, which I'm hoping I'll convince you is not an issue. So as an introduction, let us not forget the background on PPIs. They're indeed the second most commonly prescribed medication worldwide, with over 6.5 billion doses dispensed. Sales are in excess of 10 billion yearly, and side effects have been reported. They relate to the mechanism of action of PPIs, such as its acid suppression potential, relate to possible drug-drug interactions, as we'll discuss, idiosyncratic effects, which is the case for interstitial nephritis, and finally other mechanisms that we do not understand, such as hypomagnesemia, which I'll go over with you. Now, if you look at the literature and you scan the literature up to 2010, this gives you an idea between 1986 and 2008 of the number of PPI safety articles published, and it has continued to rise exponentially. So you clearly need to realize that there's probably a selection bias, and in fact I'm going to spend a few minutes on methodology to help you interpret this plethora of articles that have come out over the last little while. As a background, let's also not forget that the PPIs are amongst the most used worldwide, but there's a lot of overuse in PPIs, and indeed the inappropriate administration of PPI rates vary anywhere from 40 to 70%. And this is true in the hospital setting as well as in the community setting, and it's true not only in North America and in this area in the world, but also in Asia and Western Europe. And therefore, the name of the game is going to be the risks and the benefits. And where there are good benefits to be provided by the PPI, obviously, we may accept some risks involved. But where the prescription is inappropriate, obviously we will not. So if we want to balance the risks and the benefits, you have on this slide, on the left-hand side, all the approved indications for the PPIs, where it has been shown in level 1 evidence by randomized trials that they provide benefit to patients. And then a list, an incomplete list of the potential adverse effects that I'm going to actually tackle with you to try and understand and make heads of all of this. So perhaps, first of all, with regards to neoplasia, indeed, you get a higher serum gastrin level in association with the chronic administration of PPIs. However, although endocrine cell hyperplasia has been noted, it is reversible, dose-dependent as well, and reversible when you stop. In addition, fundus gland polyps are seen. This is also a reversible process, but neither requires stoppage of the PPIs. It's more a physiological significance. I emphasize to you what probably most gastroenterologists know is that there has been no documentation of carcinoid tumors, no increased gastric cancer, no increase in gastric atrophy at the 7-year follow-up, and no link to colon cancer. Some of these are a little bit controversial, notably the issue of gastric atrophy, but there have been problems in the literature, particularly with comparative groups. So really, with regards to neoplasia, absolutely no clear link to the development of any cancers, and this is important to convey to patients who are concerned about it. With regards to vitamin B12, hypochlorhydria does lead to decreased absorption. However, patients on long-term PPI have serum vitamin B12 levels usually within the normal range. And in fact, there are no current recommendations for vitamin B12 screening or supplementation with long-term PPI use. The patients who have borderline low levels have never developed any syndrome of subacute combined degeneration because of it. Same in iron, no definitive implications for the average patient, little data to indicate that PPI therapy causes iron deficiency. It's actually used a little bit in that context in patients with hemochromatosis, but for the average patient it is not an issue. And the reason why there is no issues with regards to B12 or iron is that you do not get complete acid suppression. It's a high-level acid suppression, but not a complete one, and you still absorb these vitamins and minerals appropriately in a normal individual. You may or may not be aware that hypomagnesemia has been associated with PPI administration. There was a black box warning from the FDA about a year and a half ago or so on this. It's a rare condition. In fact, of the 6.5 billion doses given worldwide, there are only 35 reported cases. Nonetheless, it has been noted, and you need to know about it as clinicians. It is a class effect noted with all the available PPIs of unknown prevalence. The long-term PPI use and high rates of adherence are probably risk factors, mostly in patients who've been on a PPI for at least a year. So it's people who actually follow the medication very faithfully on a daily basis for a long time who are at particular risk for this. The presentation has included in the literature spasms, numbness, cramps, weakness, lethargy, and in more severe cases, confusion and seizures, as well as EKG changes. Magnesium supplementation can relieve the PPI-induced hypomagnesemia symptoms, but in some, interestingly, it may not restore it, and you may actually have to stop the PPI. Once the PPI is stopped, it corrects quite quickly. Part of the problem here is that low magnesium can lead to low calcium, leading to the manifestations we've described. As a result of all of this, the FDA does recommend to consider testing in people who are at risk for developing hypomagnesemia or in patients in whom you're suspecting may have developed hypomagnesemia or hypocalcemia or its symptoms while on a PPI. Now, for most of the other slides I'm going to show you and most of the other associations, please allow me to wear my Master's in Epidemiology hat for a second and convey to you some very important issues. Many of you may be aware of these already. There are very few randomized trials looking at medication side effects. These are mainly epidemiological studies, in fact, so-called nested case control studies. These are purely observational, where patients are just examined and happen to have been on a PPI just through the normal flow of patient care. You cannot conclude on causation and only rather on associations with these observational trials, very different than a randomized trial. In a randomized trial, patients are randomized to one or the other group and are completely comparable except for the treatment. In observational studies, as I mentioned to you, we know who gets a PPI, we know who gets a pneumonia, we know who doesn't have a PPI and a pneumonia, but comparing both groups, we already know that most of the sickest patients get PPIs. And as a rule, the PPI patients will be at risk for a number of negative outcomes. So statistically, you can try and adjust gradually for all the confounders of known for the interest of outcome at hand. And in the case of pneumonia, for example, you'd need to adjust for age, for COPD, for the presence of smoking, etc. But you can never adjust completely because this is not a randomized trial. Again, it's just real life being observed a posteriori. Therefore, you need to be very careful about that. You need to make sure that there's biological plausibility to the association that is suggested. You need to look at consistency, make sure that indeed it is the case in many studies published in the literature. Temporality. Believe it or not, some studies have actually linked PPIs to side effects where the patients actually developed the outcome before they were started on PPI and only subsequently started PPI. Again, a problem with these large administrative databases. You ideally would like to see dose response. The greater the duration and dose, the higher the likelihood of developing the outcome. And finally, a very practical suggestion is to look at the strength of the association. Any statistically significant association in randomized trials is important, but not so in observational studies for the reasons I've mentioned to you. So you need to look at the risk ratio, the odds ratio, or the hazards ratio, and if under 1.4, 1.5, you have to wonder, even though it may be statistically significant, is it in fact due to background confounding? So the name of the game really are these imbalances possible due to selection bias, or as you'll see called channeling bias in the literature. And the key to resolving these is adjustment for confounding, which can never be done completely. So with this in mind, perhaps, let's have a look at the data. First, with regards to infections. We can see, I'm going to show you all of the different tables I show you have the following. You have the studies on the left-hand side. You actually have the forest plot with the line of unity on the right-hand side. And finally, the summation odds ratio. If the lozenge you see, the black lozenge you see here is overlapping 1, that means the confidence interval is overlapping 1, and it's not statistically significant. So with regards to ventilator-associated pneumonia, in fact, in this case, we actually have mainly randomized trials, and you can see that there is no difference between H2RAs or PPIs in the context of ventilator-associated pneumonia. So much for that association. With regards to patients who are not on stress ulcer bleeding prophylaxis, a different issue, but we're lacking data in that context. With regards to PPI community-acquired pneumonia, you can see that the level of association of the meta-analysis is actually low. It's under this 1.4, 1.5 threshold, 1.27, which already suggests that it may just be due to background confounding. In addition, when you look more carefully at the studies, they were all observational studies. There are marked limitations in findings with this weak level of association that I've described to you. In addition, our H2RA patients were also strongly associated, which makes a little bit less sense because you should see a dose response with less association in the context of H2RA. And perhaps the most important argument I would put forward to you is the issue of biological plausibility. Indeed, investigators have actually cultured the pharynx of patients on chronic PPIs and tried to relate the presence of those pathogens with the pathogens that cause community-acquired pneumonia. And in fact, presumably this is due to microaspiration leading to the pneumonia, but the pathogens are completely different in the two groups, so we're not even sure what the mechanism of action is. So in light of this, I would suggest to you that in fact there is no true association linking PPIs to community-acquired pneumonia. A very different issue with regards to C. difficile. I've been told that C. difficile is not a huge problem in the kingdom right now. I would respectfully suggest it probably will become so. That is the track and the pattern that has occurred in most other countries and regions, unfortunately. You can see here that the odds ratio is much more significant, already 2, and in certain studies close to 5. So clearly this is a different issue. There is a signal. In addition, there's a biological plausibility. We know that when you decrease acid in the stomach, you can get growing of bacteria, and it can lead, in this case, to overgrowth and to spore activation through a number of mechanisms. Therefore, the relationship to C. difficile is most likely a true one and needs to be considered very carefully. However, when trying to decide whether you should continue this in a given patient who is at risk for C. diff or not, you can actually have one more piece of information, and that's the number needed to harm. And the number needed to harm is 1 in 2,500, meaning you need to give 2,500 patients a PPI to get one patient who would develop C. difficile because of that PPI. So my suggestion to you is, in patients who are on a PPI for a clear reason, the benefits are much greater. However, in a patient in whom probably they shouldn't be on a PPI to start with, by all means use these possible associations to prescribe more appropriately. And finally, PPIs have also been linked to recurrence of Clostridium difficile associated diarrhea in actually 4 studies now in literature with very strong relationship. If you look at other enteric infections, PPIs have been linked, and in fact through the same type of biological mechanisms with very strong odds ratios. You can see that it's over 3 in this meta-analysis, linking Salmonella and Campylobacter that we know are both acid-sensitive enteric infections. So clearly, enteric infections, C. difficile, Salmonella, Campylobacter, there is an association, but the benefits outweigh the risks if the patients require the medication. Other possible infectious associations have included the issue of decompensated cirrhosis. A recent study using propensity analysis suggested that PPIs and not H2RAs were related to serious infections in this patient group. There's only one study, but something to consider perhaps. And finally, interestingly, a large cohort looking at PPIs suggested that there was no relationship, contrary to what was reported, with the incidence of small intestinal bacterial overgrowth. So that does not appear to be an issue, in this case as diagnosed by glucose hydrogen breath test. Okay, I've kept one of the most difficult topics for second to last, and that's the osteoporosis and fractures. This is unclear right now, and we now have 31 studies in the literature trying to assess the level of relationship between PPI intake chronically and the development of fractures. So let me try and walk you through this one. We can see that there are different types of fractures. This is a meta-analysis from the McMaster group published 2 years ago. You can see a very low level of association with regards to the presence of hip fracture, only 1.25. These are all observational studies, so it's low. Higher with regards to vertebral fractures, 1.5. Certainly should grab people's attention. And finally, a non-significant association with regard to wrist or forearm fracture. So the question is, do PPIs, are they associated, either in association or causal way, with the development of fragility fractures? When looking at the data a little bit more carefully, surprisingly, there's a very poor time-dependent relationship, such that the patients who are on PPIs for longer actually had a lower level of association with fractures than did the patients who were on it for a year, which doesn't make much sense. So bear that in mind. Cohort studies and stronger methodological studies have been associated with weaker levels of association. And finally, despite these 31 studies, we still don't know how PPIs might actually cause fractures. Indeed, the issue of calcium absorption is not one. With the regular calcium intake in a regular diet, there is no issue related to PPI and calcium absorption. The absorption remains normal. So then people suggested that perhaps it was due to the presence of proton pumps on osteoclasts. When you think about it, inhibition of osteoclast function should probably not lead to increased bone resorption, but quite the contrary. So then people have turned around and said, well, maybe the bones are very brittle because they cannot be remodeled as they should be. Needless to tell you, nobody knows is the bottom line at this point. Finally, the current thinking is that perhaps the vitamin B12 link with regards to proline metabolism and bone deposition may be an issue. Again, it's not clear-cut. So in the absence of a clear biological plausible argument, you have to wonder about the possible veracity of an association. Just to give you an idea of how dynamic this field is, I show you the last 4 studies have been published only in the last 6 months on the area. One is the Nurses' Health Study. You may be familiar with this. Over 70,000 nurses were followed for up to 10 years. And interestingly, in this case, they did find a temporal relationship over time with increasing exposure. However, the link was to women who smoked. Women who had never smoked had no relationship with regards to fractures, and we know smoking is a risk factor. So perhaps there's a subgroup of very high-risk patients who are at risk. There is a large Canadian prospective cohort of patients with osteoporosis that suggested an association. However, when followed over 10 years, there was no difference amongst the patients on and off PPI with regards to bone mineral density loss, again going against the fact that perhaps it's linked to fractures. And if you're not confused enough as it is, there's actually a very well done recent Japanese study that looked at, and it's a randomized trial, adding PPIs to residronate and found the residronate worked much better with regards to physiological outcomes when it was administered with a PPI. So I hope you're confused, because I certainly am, and I think most people are quite unclear about it. Perhaps the take-home message is not whether it is truly associated or not. It remains a possibility, although it's unclear. But here, too, the number needed to harm is very low. 1 in 1,800. You need to give 1,800 patients a PPI for one to develop a fracture. So my message to you is again the same. If the PPI is indicated, likely the benefits will outweigh the risks. But if it's not indicated, by all means, use these associations to not prescribe inappropriately. And the recommendation is that for patients who are at risk for osteoporosis, you need to follow bone densitometry anyways, and you should do so if they're on a PPI especially. The last association I want to spend particular time on is clopidogrel. And I would mention there's an excellent systematic review, and it's published as lead author by a Saudi, Majid Al-Madi, who's been back in Riyadh for 2 years now. And I commend him, because getting a JAMA publication during your fellowship is an unusual task. The reason I show it to you as well is because it included a cardiologist and gastroenterologist trying to bring a balanced picture of this entire antiplatelet and anticoagulation therapy issue. So perhaps I'll direct you directly to the role of clopidogrel with regards to benefits. It actually helps in decreased risk of patients who are at high risk for bleeding, whether you give clopidogrel alone and whether you give it in association with aspirin. Indeed, from the COGENT trial, we know that amongst patients who are on dual antiplatelet therapy, and these were not high-risk patients with regards to GI events, you get a very significant increase in protection with regards to GI events, a 2/3 decrease in GI events, and this includes a decrease with regards to overt gastroduodenal bleeding and overt upper GI bleeding of unknown origin. Very significant outcomes in these patients who have cardiovascular issues. So clearly, a huge benefit of adding clopidogrel of adding PPI to patients who are on clopidogrel. The question is there a downside of cardiovascular events? And we'll come back to that in a second. I told you that biological plausibility is an issue, and certainly there is a plausible biological mechanism to explain a possible interaction, because both PPI and clopidogrel are metabolized by the same enzyme in the liver, the cytochrome P450 2C19 complex, and we know that clopidogrel needs to be metabolized to its active metabolite to be able to inhibit platelet aggregation. So what levels of information do we have to look at this? Well, we have 2 levels I'm going to discard right off the bat. The first is pharmacokinetic drug interaction studies. There is tremendous variability in methodology, and in fact, every PPI maker will pull out of their back pocket an issue that will show, a study that will show that theirs is the only one that really doesn't interact. The data are all over the place as are the methodologies. I would forget these and discard them. Same with ex vivo antiplatelet activity studies. There's much heterogeneity in the results and very poor clinical relevance, and the cardiologists know this, between the outcomes of these ex vivo antiplatelet activity assays to clinical outcomes. So let me move straight to the clinical outcomes. Well, in fact, one of the most damning clinical study to implicate PPIs with regards to an association of clopidogrel with regards to increased cardiovascular negative outcomes was actually a Canadian study done out of Ontario using the OHIP pharmacological database. And what you can see is they found that amongst patients who were taking clopidogrel, if they were also on a PPI, they were at increased risk for cardiovascular events. Just to make it even more explosive, they actually found that this was true for all the PPIs, but not pantoprazole, that did not have this negative signal associated with it. Now, there are a number of problems with this study. Perhaps the biggest was the one that was noted in 12 letters to the editor that followed subsequently. In fact, the link to pantoprazole selectivity was incorrect, and there was a statistical mistake done by the group. And when you correct, in fact, pantoprazole behaves like every other PPI. So clearly there was an issue. However, the FDA made the recommendations based on these data. Perhaps a more balanced approach was that of a number of subsequent better methodologically performed studies. This includes a very large study out of the Medicaid Tennessee database published in the Annals of Internal Medicine about a year later. They found absolutely no signal between PPI use and cardio or cerebral vascular events. They actually stratified the patients between high and low risk groups and still found no signal. And with regards to PPI selectivity, in this particular context, they found a weak signal with regards to rabeprazole, but the numbers were very small, and conclude that probably you could not make much of that, suggesting no PPI selectivity of a possible interaction. When you look at the upper limit of the 95% confidence interval, it's about 1.4, suggesting that it's possible that you have a weak interaction that could be as strong as that. However, it was not statistically significant. And in fact, it's the editors of the annals, not an invited editorship, that gave the editorial on this paper. And they concluded that there was likely no PPI specificity. If any interaction, it was at best or at worst a weak one.
1 minute.
And so should weigh the risks and the benefits. I do want to show you the results of the Cogent study that was performed that shows the advantage in GI bleeding, but absolutely no difference in cardiovascular events, suggesting the absence of any significant interaction.
You exceeded your time, please.
I'm sorry?
You exceeded your time.
Oh, okay, thank you. And indeed, with regards to cardiovascular events, when you look at the different rates, there is no difference of the different. So what you have are patients who benefit tremendously from PPIs, preventing significantly GI events, and on the other hand, absolutely no suggestion of a significant interaction. And this was a randomized trial, where both patient groups were completely matched. You could not ask for better. The problem with this study is after 3,800 patients, the study was stopped because the company went bankrupt, and the FDA suggested that they could not look at the study because they were supposed to include 5,000 patients. So based on this, the FDA rejected looking at the strongest possible evidence we had, which is that of a randomized trial. Further data suggesting that there's no PPI selectivity. I'll skip this and I'll go straight to the conclusion. So the majority of the studies, there are now 3 systematic reviews in the literature that have suggested indeed there's a signal that is present between a possible association between clopidogrel and PPI. However, stratified analysis based on study quality demonstrates an inverse correlation between study quality and a positive outcome. The best studies did not show an association. None of the 18 studies found a clinically meaningful difference between the various PPIs. There is no PPI selectivity. It's as simple as that. The data are clear. And finally, interestingly, if you're still not convinced, the observed timeline of suggested cardiovascular side effects resulting from possible interaction is not congruent with the window of benefit of clopidogrel. Clopidogrel is particularly good for a month following the acute event and becomes less and less efficacious thereafter. Most of the cardiovascular events that occurred here occurred well outside that window, which makes little biological sense. And in fact, most cardiologists and gastroenterologists worldwide experts believe that in fact there is probably no PPI clopidogrel interaction. And as I mentioned, this has been confirmed by 2 other meta-analyses to date. Finally, before finishing, what I'd like to do is just discuss with you a very awkward issue, and this is that of PPI discontinuation and the presence of rebound symptoms. In fact, PPIs may actually, it has been proposed, induce the very symptoms they are commonly used to treat. We've been accused of causing a generation of addicted to PPIs, and as soon as you start stopping the PPI, patients get more reflux that they shouldn't be getting, that the PPI is causing. So there are 2 randomized trials that have looked at this, looking at healthy subjects, using esomeprazole 40 for 8 weeks or pantoprazole 40 for 4 weeks. And what you see, indeed, 44% of patients who were healthy developed transient symptoms of GERD or dyspepsia after stopping the PPI of varying magnitude, usually relevant only in the first week. The problem is the outcome measure. These were not symptoms that were looked at, but actually scales, and the difference in the scales were statistically significant, but not clinically significant. In addition, none of these patients had GI symptoms to start with, and in fact there is no clear clinical trial evidence of undue difficulty in reducing or discontinuing PPI treatment in patients with regards to NERD or erosive esophagitis. So the data are still out, but the so-called rebound hyperacidity that may be related to stopping a PPI is of unclear significance right now. So what to do with regards to PPI side effects? They're highly effective in GERD, non-varicella GI bleeding, and prophylaxis of NSAIDs and antiplatelet medications. PPI should only be prescribed when there is an appropriate clinical indication. You need to weigh the risks and the benefits, advise the patients accordingly. Minimize duration of therapy, periodically review the needs for a PPI. Avoid initiating a PPI for non-urgent conditions in patients on antibiotics or at risk for enteric infections. Increase daily calcium intake, which should be done anyways. Vitamin B12 levels and bone density should be checked in the elderly anyways, and that if they're on PPIs, then so be it. Limit use of NSAIDs and antiplatelet medications in the first place is also an important aspect, rather than aiming for the PPI. So in conclusion, I think the PPIs are clearly linked to C. diff and other enteric infections. However, all other associations are weak or disproven, with the question about the fracture risk, which remains quite low. PPI clopidogrel, there may be a weak interaction. However, if it is present, it's with minimal clinical impact, which by far is outweighed by the benefits if indeed the patients require it. The clinical relevance of rebound acid-related symptoms remains unclear. But again, if indicated, the PPI benefits outweigh the risks. However, in light of all these possible side effects, please let us use that to prescribe appropriately. And as in everything in medicine, let's weigh the risks versus the benefits. Thank you very much for your attention.
Thank you.
Shukran.